So for your assessment for these, for all of these, you want to, of course, perform your initial and primary assessment. You want to locate and treat life threats. And this can include femur fractures and pelvic fractures. Because these, if these are fractured, these are life threats. 2 femurs or 1 pelvis, or a femur and any other long bone, or anytime you have basically multiple long bones, like your legs or your arms. Those are significant fractures. You can bleed a lot, and that's really the concern with that. So we look for signs of bleeding with our primary assessment, and I don't think it's inappropriate for us to consider the fact that pelvic fractures mean bleeding. It's just not external, it's internal. Then assess, of course, for injuries of the head, chest, abdomen, and pelvis. And if we find anything, well, we're going to assess initially distal neurovascular function. So when we talk about that, you're going to look in the hands and the feet and basically assess for circulation, motor, and sensory. And this used to be pulse motor sensory. And we would abbreviate this CMS. It used to be PMS, and then some people got upset about that. So circulation, motor, and sensory. So circulation you can check by looking at cap refill or pulses, or both actually is best. Check motor. Ask them to wiggle their fingers, wiggle their toes, move their hands up and down, and move their feet forward and back. And then sensory. And ideally you check for light touch and then kind of that pinprick style touch, because they're two different receptors there. So light touch, so you just kind of run your finger lightly on their hand, and then pinprick, you take like a paper clip or a staple, a needle, and you just kind of lightly touch and see if they can feel that over a few points as well. So with the exception of pelvic and possibly femur fractures, and by femur it's really either bilateral femurs or any 2 long bones. So if you have a humerus and a radius ulna, then that's going to be significant. Orthopedic injuries are not usually life-threatening. And the reason that these are is just because of the associated bleeding. So don't let the spectacular orthopedic injury distract you from the ABCs, because it's the unobvious things that kill the patients. Maybe they have a really mangled broken arm, and you're so busy with that you don't recognize that they have a rigid, distended abdomen and they're bleeding internally. So don't worry so much about the orthopedic injury. Notice it, note it, and then do your primary assessment like you should. Come back to the orthopedic injury when you get a chance. So here's the thing. I mentioned the distal neurovascular function. Remember, neuro is nerve and vascular is vessels, blood vessels, right? So check the nerves, check the vessels. We want to assess pulses, skin color, capillary refill, sensation, and movement. We want to make sure that all of those things are present, and we want to be sure to document them. So splinting. Splinting is a great thing for us. Splinting prevents further movement at the site of injury. It limits tissue damage, bleeding, and, believe it or not, it really does help with pain when the patient is not constantly moving it. When you're in doubt, splint it. If the patient expresses concern that they have an injury to an arm or a leg or, a joint, then just splint it. It's going to make the patient more comfortable. It's really difficult for us to differentiate between fractures, dislocations, and sprains. So just splint them. So some quick principles of splinting. If you can, do not move the patients before splinting unless the patient is in danger, because if you move them, it's really going to hurt, and then why bother splinting at all if I've already hurt my patient? Remove the clothes to allow inspection of the limb. Note and record the distal neurovascular function, so CMS or CSM, if you prefer that order, whatever works for you, before and after splinting. So check it before and check it after. And I want you to think about, why do we want to check it both times? The reason is that we want to verify that our splinting has actually not made the problem worse. If there's any wound, be sure to cover them with dry, sterile compression type dressings. That's not actually compression dressing. And a lot of times the splinting will help provide some compression. So cover it with dry, sterile dressings. For fractures, you're going to splint the joint above and the joint below the fracture. So immobilize, if this is a fracture, we're going to splint. Immobilize the ankle and immobilize the knee. For dislocations, you're going to splint the bone above and the bone below the joint that you're splinting. So if it's this knee, you're going to basically splint the femur up here and the tib fib down here. For principles of splinting, you're going to minimize movement, support the injury until splinting is completed, and pad the splint to avoid local pressure. So we want to basically keep the splint padded. You can see these are actually called board splints because they're just padded boards. And then they've got a layer of padding around this to help distribute the pressure all over. And they've got this tied in a few separate places. So for angulated fractures, if you can realign it before splinting, then do so. We want to basically think the neutral atomic position. Neutral atomic position. Anatomic, not atomic. Thinking chemistry here. Anatomic. Silly. Okay, so the neutral anatomic position. And remember your anatomic guy. He's got kind of his hands facing forward and his feet pointing straight forward as well. So just think about that. If resistance or pain is encountered, stop and immobilize it as is. And you may have to get creative with this. For dislocations, you're going to splint as is unless circulation is compromised. You can reposition it once to try and restore the pulse, but if resistance or pain is encountered, then stop and immobilize it as is. And that's it for musculoskeletal injuries. And we're going to get plenty of bandaging and splinting practice. So bring any questions with you to class. Thanks.